Hi, and welcome to MedInsights Unleashed podcast. I'm John Collins, and I hope you enjoyed this new episode, and thank you for listening. Hi, listeners. Today on MedInsights Unleashed, we're discussing advanced thyroid cancer and how neoadjuvant therapy may improve surgical outcomes while preserving critical structures and function. Joining us is Professor Gregory Randolph, Bertucci Chair in Thyroid Surgical Oncology at the Harvard Medical School. Professor Randolph is a world-renowned leader in thyroid cancer surgery, and today he'll discuss the Phase 2 results evaluating the neoadjuvant use of lenvatinib, nerve preservation, vocal cord recovery, and the future of advanced thyroid cancer management. Professor Randolph, welcome to MedInsights Unleashed. It's a great honor to have you with us today.
Well, thank you so much, John. I'm very gratified to be here with you, my good friend and collaborator for now many years. It's lovely to be here with you and your audience. And I would love to answer any of your questions, but to basically share information on something that is fairly new initiative within thyroid cancer treatment. My area of work has always centered on more advanced thyroid cancer. That is, if you think of cancer as a lump or nodule within the thyroid gland, is bow tie shaped and bow tie positioned. So the two bows are the two lobes, the knot is the isthmus that connects the two, and it's in a bow tie type position in the neck. If you think of a cancer develops as a lump or nodule within one lobe of the thyroid, a way to think of that is if you think of that lobe of the thyroid as like a hard-boiled egg, you bisect the hard-boiled egg and the yolk is the nodule. So it's a lump that is a density within the substance of the gland. That's all well and good and generally well treated when the nodule is contained within the thyroid gland with thyroid surgery, and outcomes generally are quite good for the majority of thyroid cancers, but not every thyroid cancer is like that. There are about maybe 15% of thyroid cancers are locally invasive. And the way to think of that is think of that yolk of the egg, that nodule, that cancer that's in the lobe is now escaping outside of the white of the egg. It's growing through the thyroid gland into the surrounding structures, which are very vital structures: the trachea, the windpipe, the esophagus, the swallowing tube, the carotid artery, one of the main arteries that goes to the brain, the spinal column posteriorly, the nerve that goes to the voice box, the wire that powers the movement of the vocal cord underlying voice and swallowing. Very precious structures in the neck. So when that cancer in these 15% or so of cancer patients extends outside of the thyroid cancer, there are some very significant effects, and the surgical management of those effects are very significant, difficult to manage.
Sorry, is there a check thing that patients can do to monitor their thyroid?
Well, there is, for thyroid, the bulk of thyroid nodules or lumps in the thyroid are typically benign, and they are generally they typically are not symptomatic. Like a cancer doesn't have typically pain or something that would herald its presence. Generally, women in the shower where they're washing their neck and feel their neck may be able to see or feel an asymmetric lump. Men, when they shave or put on their tie, typically will be able to feel an otherwise asymptomatic nodule in the thyroid gland. So those are ways typically that these cancers are identified. Unfortunately, they don't typically give pain. If you do have extrathyroidal extension, then there can be growth. As I mentioned, one of the structures that the cancer can grow into if it extends out of the thyroid gland is the nerve to the voice box, in which case then the voice can get breathy. the vocal cord doesn't move inward if it's paralyzed from cancer growing into it, and so you get this kind of breathy quality to the voice. The other consequence of that is that you can get a aspiration of liquids. So liquids, especially liquids, find every inaccuracy in the throat, and so liquids especially can prompt a cough. So that's not common. Again, extrathyroidal invasive disease is only present in about 15% of patients, and only a subset of them may have nerve paralysis. But certainly, voice changes is something that we attend to in any patient with thyroid cancer, given the potential for nerve involvement.
Is there a family history?
Generally, there isn't. The most common type of thyroid cancer, actually the one that we studied in the clinical trial that we will discuss in a few minutes, is differentiated thyroid cancer, which is the most common form of thyroid cancer. The most common subtype of that is called papillary thyroid carcinoma. That is the one that is generally most well behaved, best prognosis, and is certainly the one that's most common. But there are many different types of thyroid cancer, and one of them is called medullary thyroid carcinoma. And medullary carcinoma can be, in about 25% of cases, inherited. That's the known one inherited type of thyroid cancer. And even medullary carcinomas are primarily not inherited, but about 25% of them are. That is, you inherit a gene which increases your risk of the development of medullary carcinoma. But again, the answer to your question is the majority of thyroid cancers and all differentiated cancers are basically not inherited, but a subset of medullary carcinomas are.
Are there biomarkers associated with this?
There really is not any blood test that helps with the identification of routine papillary thyroid carcinomas. Unfortunately, it's really the identification of a lump and then its biopsy workup that reveals the cancer typically. Medullary carcinoma, when you're working up a patient with medullary carcinoma, there is a specific marker called calcitonin that is a hormonal marker of that specific type of cancer, of specifically medullary thyroid carcinoma. People are not screened with calcitonin. If you think it's a medullary carcinoma, you get a calcitonin to help confirm the diagnosis, but that there isn't a role for calcitonin screening of the population.
And anaplastic is another very aggressive, from your perspective as a surgeon, how do you treat anaplastic?
Yeah, anaplastic carcinoma is a rare type of thyroid carcinoma, but is one of the most aggressive human cancers that exists. We think that anaplastic carcinoma, in a majority of cases, starts as a more routine, mundane, lower grade thyroid cancer, such as a papillary or follicular differentiated cancer in the majority of cases. And, every cancer, even fairly low grade papillary and follicular carcinomas like we're talking about, are driven by mutational errors in the cell that cause the cancer to evolve from the normal cell. And so every cancer has a mutational profile to it, even the low grade papillary and follicular cancers. Most of those low grade cancers stay low grade, but some of them, we think, the errors that were initially in the cell to form the initial cancer then lead to a cascade of additional errors, the accumulation of additional mutations beyond the initial driver mutations that resulted in malignant transformation in the first place. Those accumulated mutations then are responsible in a rare subset of patients for the development of anaplastic carcinoma. So that you might have a papillary carcinoma there for several years, and then all of a sudden, additional accumulated cascading molecular changes are accumulated, and then that cell explodes as an anaplastic carcinoma, which has arisen from the preceding lower grade cancer. We think that's how anaplastic carcinoma arises. Anaplastic carcinoma is difficult to treat. It is very rapidly growing, local regionally in the neck and also in other parts of the body. The real initiative with anaplastic carcinoma of the thyroid gland is in the subset which is about maybe 40 to 50% of anaplastic carcinomas that are BRAF driven. When you have the BRAF mutation, so not all anaplastics have that, but when you have a BRAF mutation in an anaplastic carcinoma, that renders it susceptible to a specific set of agents, dabrafenib, trametinib, and immunotherapy. And these agents can be given immediately at presentation and cause the tumor to slow down its growth, regress to some extent, and in many circumstances may allow surgical removal of the tumor at least more successfully than without these medicines given prior to surgery. So the big news in anaplastic carcinoma is when it is BRAF driven, when there's a BRAF mutation, there are new medicines that can be given to control the tumor and potentially allow for more successful surgery.
Professor Randolph, you're at the cutting edge of neoadjuvant therapy. Would you now like to step into the cases that you're treating from a neoadjuvant perspective and talk about how you actually developed the neoadjuvant trial and what sparked that passion in you to really go to the forefront?
Well, so my practice has always been oriented towards more advanced thyroid cancers and how can we get the cancer out, but do so with a minimum of morbidity. Some of the structures in the neck that we discussed, trachea, esophagus, nerve to the voice box, carotid artery, these are very precious structures. And when you have to start surgically resecting them because cancer is involved, the the surgical complexity for the surgeon, the difficulty in reconstructing the defect that you've created, and the morbidity for the patient are really escalate significantly. So it was actually, but in the past, that's all we had. So you would just go to the operating room and you and the patient, especially the patient, would take their lumps, and you do the necessary surgery that was needed. It was good and necessary work, but I thought, how clumsy was this that we're only using one modality of therapy? Might we be in a better position if we try and pre-treat the patient with an agent to try and get the tumor back on its heels a little bit, retreating, and then maybe we will have more optimal therapy. So it was my surgical experience with advanced cancers, but then reading a paper. I remember I would come into the office on Saturday mornings. And the reason I did that is that I wouldn't have any surgeries to do. I wouldn't have any clinics to see. I could just sit at my desk with a blank piece of paper in front of me, a pad of paper, and think a little bit. And one of those Saturdays, I was reading a paper on the SELECT trial, which is Martin Schlumberger, a renowned endocrinologist in Paris, had written a paper looking at his experience treating patients with distant metastatic spread, so lumps of tumor in their lungs from advanced thyroid cancer, papillary and follicular cancers, differentiated cancers that were aggressive and associated with distant metastasis, typically pulmonary metastasis. And he looked, and this was a paper in 2015 published, and he looked at the efficacy of an agent called lenvatinib, and it was remarkably effective in shrinking these tumors in the lung. Volumetrically, it would be about a 30% decrease in 2/3 of patients treated. So that got my attention, looking at seeing how effective this agent, this new agent was for patients at least with distant metastatic spread. And then when I read further in the paper that shrinkage occurred typically within the first several months of treatment, I nearly fell off my chair because I thought, give me some of that to my patients presenting, walking in the front door with advanced cancer. Even a millimeter or two of shrinkage, never mind 30% volumetric reduction, would undoubtedly have a positive effect on subsequent surgery. Whether it made the structure that the cancer was growing into free or separable or not, we would have to wait and see. But give me some of that, you know, then time the surgery when the cancer was retreated, and then intervene strategically, partnering with your medical oncologist to give the medicine, then do the surgery when we all agree it would be more strategic. So that was really the impetus of the of the study that looked at the application of that agent, lenvatinib, in the neoadjuvant therapy. That is, neoadjuvant before the main therapy. The term is neoadjuvant. So you give the medicine prior to surgery. That's the neoadjuvant treatment. Surgery being the bulwark, the main therapy. So, and I partnered with you and others to introduce that idea. That there were, but it's interesting. There is always risk, right?
Yeah.
So that the efficacy of lenvatinib is associated with some side effects. There are side effects that can sometimes cause bleeding from tumors. There are side effects that can sometimes cause fistula. Fistula is where the tumor is growing into some visceral structure in the neck, and then an opening is created in that structure, whether trachea or esophagus, and then fluid and other material leaks through the skin. So very significant problems of bleeding and basically breakdown of tissue called fistula. And so we were proposing then, giving an agent that was associated with bleeding and fistula formation and then operating on patients. So we thought, that's a little, that's unintuitive, right? But I was so convinced that the surgery would be more strategically offered by first giving the lenvatinib, we went ahead. And, we very carefully, and this is all, the devil is in the details, is very carefully construed the study to look at the application of this agent prior to surgery in a way that would be very safe. So, for example, we excluded patients with gross tumor in the airway, thinking they would be at risk for bleeding, patients with carotid encasement, where tumor would be growing all around the carotid, were excluded because we thought these would be a setup for bleeding. So we tried to study a population where we could determine advantage of this approach, but also do it in a way that wasn't patently risky for the patients. And that was really, those thoughts were all the initial thoughts in the creation of our lenvatinib as neoadjuvant therapy prior to advanced thyroid cancer study.
It was a multi-centered studies.
Right. So this is a phase 2 multicenter study. There were 3 centers involved, 30 patients, approximately 30 patients accrued, and it was Harvard, my center, which is Mass Eye and Ear, and Mass General Hospital at Harvard Medical School, was one center. The second center was some of our friends at MD Anderson, Mark Zafario and Naifa Busadeh, surgeon and endocrinologist combination. And then at Memorial Sloan Kettering, Rich Wong, one of our ex-residents at Mass Eye and Ear, who is now head of the head and neck service there and a good friend, and Eric Sherman and Alan Ho, two medical oncologists at Memorial Sloan Kettering. So really a very, very good group of people who were our good friends, all felt that this was a great idea. And so we studied these. It was actually 28 patients at those 3 centers, all treated basically in 3 different centers, but treated exactly the same way, the same inclusion criteria, the same methodology for the study. By the way, the methodology of the study was basically patients come in, they are defined by clinical evaluation to have advanced invasive thyroid cancer. The way we term it is the margin status of a cancer. If you think of cancer as a ball that's sitting in the neck, so if you remove that cancer and get all of the cancer out, that's called an R0 resection. That means the margins are all negative. All cancer has been removed. That's a pathologic definition. The margins are
Mm.
assessed pathologically. If you take out the tumor and there is a microscopic positive margin, that's called an R1 resection. That means there might be There may or may not be, but there might be perhaps microscopic disease left in the patient. So in general, for differentiated cancers, R0 or R1 resections are considered successful. So, but R2 resections, and I'm just going through this nomenclature, R0, complete tumor resection, R1, microscopic positive, those are both considered successful surgical outcomes. The R2 resection is where gross disease is left in the neck. That is, there's actual visible tumor still left, and everyone feels that that is a failure of surgery. You've not really helped the patient when there's an R2 resection. So we looked at the study to sort out for patients who present with invasive disease, who met criteria that where we thought the lenvatinib would be safely given, no gross tumor in the airway, no carotid encasement. Then we would give lenvatinib for 2 cycles and then reevaluate with x-rays. If they tolerated it and it looks like it was working, we had the option of giving 2 additional cycles, then again look with x-rays to see would surgery be more opportune now. And we would also have the option of, if they tolerated it and it looks like it was continuing to work, to give an additional 2, a final 5th and 6th cycle, and then reevaluate them. So basically it was
How long is this cycle?
a cycle is about a month. So we're talking about anywhere from 2 to 4 to 6 months of treatment with lenvatinib, each 2-month increment reevaluated with x-rays to sort out really, if the patient, we would basically continue treatment as long as the patient was tolerating the therapy and it looks like the tumor based on x-rays was shrinking. And we would keep that going potentially up to 6 months. If the patient didn't tolerate the therapy or it looked like the progress of tumor shrinkage was halting, then we would intervene with surgery at that time. And we were very gratified with the results of the study. So the basic issues is that of those 28 patients enrolled in the study, over 80% were able to move forward with surgery. So you're taking these complex,
Amazing.
invasive disease patients and bringing the vast majority of them to surgery. And even more amazing, I think, than that is that of those patients operated on, remember I said R0 or R1 resections are considered successful surgery for differentiated cancer. So the vast majority tolerated the therapy and were able to move forward with surgery. And the surgical outcome was over 70% of those operated on had R0 or R1 resections. So a dramatically large signal. Again, there's no control group of patients not treated, but that is a tremendously outstandingly bright signal suggesting that it's tolerated well and the majority of patients so treated get to the operating room. And of those patients brought to the operating room, the majority, over 2/3, have very successful surgical outcomes. I just want to mention one thing that I'll mention one other thing about the clinical trial, but the clinical trial is absolutely essential. It's good science. It shows there's an important signal in this, but it is important to continue our work on this new treatment modality for advanced cancer through real world registries, because the clinical trial is a luxury. Patients are excluded or included in order to determine safety, but not every patient that walks into your room, your clinic, will be fulfilling those criteria. You may have some people with gross tumor in the airway. You may have some people tumors that broadly are involving the trachea, where you think a fistula could occur from giving lenvatinib. You have a variety of different complex patients that bring to you a whole variety of sometimes chaotic issues, and they all need to be treated. You can't just say, no, you're not a clinical trial patient, go home now. So this clinical trial is the first science that needs to be done, and it shows there's a immense signal of benefit from this type of approach. But to determine how this really pans out for everyone in the real world, registries will be important so that we can look at a variety of centers, all comers, intention to treat with neoadjuvant, and figure out how many patients can't tolerate the therapy, how many patients have complications from the therapy, how many patients have to bail out of the therapy, and ultimately how many patients have good surgery from the therapy.
Would the protocol then be extended out to the registry? So from any patient entering
Well,
that,
there wouldn't be a protocol for the registry. The registry would be all comers,
all
you know?
comers? Yeah.
So they would be aware of the clinical trial protocol, plan A, but it would be all comers. So they would, that's the idea, is that they would be potentially treating patients that would not have been able to be enrolled in the clinical trial, so that we can really learn in the real world without
Yeah.
these artificial exclusion and inclusion criteria. One thing I did want to mention, though, just to go back to so registries are very important, and the International Thyroid Oncology Group, which I have the honor of being president of, is in the process of setting up a real world registry for looking at neoadjuvant therapy really around the world. We have centers from Latin America, from Europe, and the US, all who will be compiling their real world data, so we'll have a better signal of how this therapy performs in the real world. I did want to mention one thing, though, that the other major finding from the clinical trial is that lenvatinib, although known to have VEGF activity, which can be associated with bleeding or fistula formation, that there were no adverse events relating to bleeding or fistula during the neoadjuvant therapy or around the time of surgery. So I think that just emphasizes the importance of, when a clinical trial is construed, you want to make sure that you are selecting patients that are optimal for being able to tolerate this therapy. And I think that's one of the reasons why we had such a positive experience with adverse events, and that did not include fistula or bleeding. So the therapy basically was very well tolerated, is the point.
Did you see from the scans that rapid reduction in
Well, it's
tumor
interesting.
size?
When you look at the scans as a patient is treated, 2 months scans, 3 and 4 months scans, 5 and 6 month scans, the average patient was treated 4.5 months. So most patients went either 4 or 6 months. The the scan, it's very subtle. The volumetric reduction of the tumor, if you think of the tumor as a little circle in the neck associated with the thyroid and to some extent coming out of the thyroid and invading local structures, if you think of that tumor as a circle, the circle did get smaller, but it got smaller only to a very small extent, maybe about 10, 15%. It definitely shrunk, but not dramatically. It didn't go away. But if the circle at presentation prior to treatment had a rim around it that was very fuzzy, invasive, that peripheral margin of the tumor on subsequent scans got much more clarified, much more discrete, much more round, much more pushing, much more discrete, less fuzzy. And we think that's associated with the shrinkage back of the invasive front of the tumor that is the thing that is causing it to be attached to the nerve or trachea or esophagus. And that is very clear cut. You can see that increasing nodularity, increasing discreteness of the tumor relative to the surrounding structures. That which was very fuzzy and invasive initially gets much more defined,
Which is a good thing from a
which is
patient
a very
perspective.
good thing.
From the patients listening
When a
to this
tumor
is
has
amazing.
a invasive front, it's attached to the surrounding structures. When a tumor has a pushing front, it is discrete from the surrounding structures. It may be pushing into them, but it is separable from those structures.
So what happens now from your perspective, other than the registry? Are you continuing on with the research in those three centers? Or has the trial now come
Yeah,
to a
well, right now
conclusion?
we've reported we are still analyzing the data. It's a very meticulous and detailed, extensive process, writing up all the data. The other piece that we want to look at is not only margin status, but was the surgery able to be reduced? If you think of just conceptually, you think of that little circle extending into some visceral structure. So the real issue that I wanted to study with this trial was two things. One is, was the ultimate margin status adequate? And we've proven that overall, yes, 80% get to
Mm.
surgery, 70% have R0 resection. The other piece I want to look at is breaking down that interface between the tumor and the surrounding structures. The histologic options that tumor has when it extends out of the thyroid is five: muscle, cartilage, larynx and trachea, esophagus, blood vessel, nerve. These are the five different histologies that are up at bat when the cancer escapes out of the thyroid. And I think each one may have a different profile of benefit. So we wanted to look at the margin status for all of those histologic subtypes, but also we wanted to sort out, was the thing that was involved as a potential R2 interface removed at surgery or not? My hope with neoadjuvant therapy is twofold. One is, can we get a better margin? The second is, can we do less surgery? And I think I would say the answer to these questions is the margin status is clear, 70% R0, R1 resection. But just to give you an example of this resection, of all of the structures that the cancer can grow into, the nerve is probably the one that is tremendously meaningful. And that seems, it's a hair-like structure. It's a millimeter or two wide. When cancer involves it, I was thinking, if you can only get a millimeter or two shrinkage, I might be able to preserve that nerve.
Mm.
And so we are still looking at all of the data, but we do have some information as to the nerve. So we have, of the 28 patients in the trial, 10 of them had nerves that the surgeon said, I will need to resect this nerve when I go in to surgery. So 10 of those patients had an R2 interface, the perception of the surgeon prior to surgery. Of those patients, one nerve needed to be resected.
Wow.
So it seems like perhaps the nerve is the poster child of benefit when it comes to this shrinkage of tumor, that it looks like we can not only get a better margin overall, but perhaps preserve structures important like the nerve. The other thing that is also actually really remarkable when it comes to neoadjuvant therapy and the nerve is not just that only 1 out of 10 nerves needed to be resected with the introduction of neoadjuvant therapy, but also it's not uncommon when you have advanced disease invading the nerve that the nerve is paralyzed preoperatively. The tumor has grown out, grown into the nerve, strangled the nerve isn't working, patient presents with voice abnormalities. So that happened. Of our patient population in the study, we had 5 patients who presented with vocal cord paralysis. It's a common presentation for patients with advanced disease. The nerve is one of the most commonly involved structures, and if it's involved to a significant extent, you have vocal cord paralysis at presentation. I had been taught as a resident many years ago that once you had carcinomatous involvement of the nerve, that nerve was dead forever. That's what we were taught. That's what we thought. In our study, we found that 1 out of the 5 patients with vocal cord paralysis had a recovery of vocal cord paralysis prior to surgery. Absolutely remarkable effect. We've written a case series of patients like that, but we've called it the Lazarus effect because it's a dead nerve that then arises back up and functions again, which is really remarkable when you think, I mean, these are small numbers, nascent study, but 1 out of 5 is 20%. So we may have as much as a 20% recovery of patients who are presenting with advanced disease involving the nerve with vocal cord paralysis, up to a 20% recovery of nerve function, which is just absolutely.
It's off the charts.
It's off the charts, and it also makes you understand the thing that I like about it most is that it gives us insight into the pathophysiology of nerve invasion. What we thought about it isn't true, that it kills the nerve definitively. The nerve has more resources than we gave it credit for. It's able to be dysfunctional, and if you give an agent that is dramatically effective, that nerve can come back, which is, just absolutely remarkable. So the issue of can we do less surgery? The issue of margin status is clear. The issue is can we do less surgery just in terms of the nerve? The answer is yes. Only 1 out of 10 nerves that were felt to be invaded need resection, and 1 out of 5 nerves that were paralyzed came back. So the effect on the nerve I say is the poster child of benefit for neoadjuvant therapy. So it's really quite remarkable.
So, for our listeners, Professor Randolph, how do you summarize what your experience has been since you've started this trial? You really have done it just in those words that you finished there. But from a patient perspective, what would you be telling patients now to
I would
do?
say it's in my career, I've seen 2 advances that I think are really important changes in the way we've managed thyroid cancer. One is with electrical neural monitoring, where we can stimulate the nerve and obtain information that our brains and our eyes can't give us by looking at the nerve. And that has changed thyroid surgery, I think, around the world forever. This neoadjuvant therapy is the second. It's applicable to a smaller group of patients that have, unfortunately, much more advanced disease, but this is a very difficult set of patients to manage. And it makes sense to me that, I kind of describe it as like if you have a difficult enemy, you send in the artillery first, damage them badly with that, then send in the infantry. And that's how I see the surgery is the most important therapy to be able to get out the tumor adequately. Everyone, medical oncologists, endocrinologists, certainly surgeons will admit resection, good surgery to resect all the tumor is the strongest anti-cancer therapy that exists. So why not sharpen your blade? Why not do it when it is most strategic, which is after pretreatment with an agent? So I think this is really going to be applied very broadly in the future. There are lots of different types of cancers. There are lots of different types of agents. So the landscape of what tumors this is applied to and what agents are used will likely change. But I think in the future, I tell my fellow that it will be undoubted that when you present a case in a, say, tumor board of advanced cancer, people will be saying, "Hey, wait a minute, I didn't hear you. What did you pre-treat with?" Like that will be what is done routinely for patients with advanced cancer. It's interesting how that might be applied. Like even if you have a younger patient with a smaller tumor with nerve involvement, but if the nerve is involved, even if it's a young patient, even if it isn't widely advanced, the data we have on nerve preservation and nerve recovery would suggest that even in that patient with much more limited invasion, they may be appropriately treated with neoadjuvant
Wow,
therapy. Also,
that's
in
great.
patients, for example, with medullary carcinoma of the thyroid, even if it isn't invasive, if it spreads to lymph nodes in the neck, the efficacy of surgery in zeroing out the tumor marker calcitonin is very,
Mm.
very poor. There are some agents that are dramatically effective in medullary carcinoma. So I'm thinking in the future, even non-invasive medullary, which is loco-regionally advanced with nodal disease, will likely be treated with neoadjuvant therapy prior to surgery just to kill out the smaller sister nodes that are near the node, shrink down the nodes, allow that the surgery is to some incremental judgment better because the just straight to the OR without any pretreatment for medullary with nodal disease in the neck is just not a very effective therapy. So I think it's interesting to see how we might expand neoadjuvant therapy to lesser forms of invasion or even in more advanced cases without frank invasion. I think that's going to be the next step.
Last question before we close, Professor Randolph. Robotics. in surgery?
Yeah,
How do you
well, I think it has not really been dramatically proven to provide tremendous benefit. It does add time and certainly expense to the case, and I don't know if those downsides have shown an upside of better quality surgery. So I would say, although it has in many types of surgery, I would say in neck and thyroid cancer surgery, it is yet to show its significant advantage.
Well, Professor Randolph, it's been an honor to have you on the MedInsights Unleashed show. I'm sure the patients and caregivers and healthcare workers that are listening to this episode will really enjoy it. They've learnt a lot from you this morning. You're an amazing person. Got a fantastic team at Mass and INE. It's just crazy. And thank you very, very much for all that you do for patients globally as well as locally. Thank you.
Thank you so much, John, and thank you to the audience for kindly listening.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.